have come to realize cardiovascular disease is a lifestyle disease and is completely preventable. There have been studies showing if you're older than 50, you start to losing weight in the range of 30 to 50% of weight loss is muscle.
Today we're going to be speaking about one of the most rapidly evolving areas in medicine, and that's GLP-1 based therapies. I'm joined by Dr. Zhaoping Li, who is an expert in this field and also works at UCLA Health. Would it be okay if we run through a case?
Of course.
85, he has type 2 diabetes. He lives by himself, and he's starting to have trouble with mobility.
How much does he weigh?
He was around 300, 350 pounds.
If you gain weight afterwards, you cannot maintain, and you are older than 50, and the weight gain is almost 100% fat.
Wow.
All right. And there is another side effect come along with this class of drug. This is actually mood change, depression.
Welcome everyone. My name's Dr. Matthew Mulroy. I'm a geriatrician at UCLA Health. Today we're going to be speaking about one of the most rapidly evolving areas in medicine, and that's GLP-1 based therapies. As geriatricians, we're seeing these medications used more and more, and while the benefits are very significant, so is the complexity. To help us better understand this topic, I'm joined by Dr. Zhaoping Li, who is an expert in this field and also works at UCLA Health. Thank you so much for joining us today, Dr. Li.
All right, thank you for having me. And this is for sure a very important topic. We are all excited about this new class of a drug in our toolbox to deal with obesity and overall obesity-related medical conditions. I would be more than happy to discuss this topic, particularly in the relevancy with your practice, that is geriatric medicine.
Absolutely. To start off with, could you tell us a little bit about your background and how you became interested in this field?
Of course. I had my MD and PhD at that time focused on cardiovascular health. And along with the time, after my basic research training, I have come to realize cardiovascular disease is a lifestyle disease and is completely preventable. From that point on, I moved upstream for preventive cardiology and further focus on nutrition, looking at how food interact with our body, how that impacted our aging, and particularly healthy aging, how that can play a role in chronic disease prevention and treatment. As an internal medicine trained physician, as you specialize in geriatric medicine, I specialize in clinical nutrition. I'm one of the nutrition physician specialists.
I'd like to hear about your thoughts on GLP-1s. Can you tell us what changes you've seen in the past few years with these therapies?
Okay. We've been struggling to looking for effective drug therapy because even first-line recommendations, lifestyle change. We all want to do that. Boy, it is hard. Easy to say, hard to do. We do need tools to help us to do that. Like our geriatric patients have difficult to ambulate. We need to find a cane to help them rehab, and to the point they can walk better. Same here. On top of first-line therapy, lifestyle change, we're looking for pharmacotherapy. Before GLP-1 become available for weight, we had a few drugs available to help patients, but the weight loss, efficacy is somewhere, 10% or less. At this new class of drug, GLP-1s, you're looking at weight loss from 15% to 20% range. It is getting close to what we have been able to accomplish with bariatric surgery, but not through surgical procedures.
Mm-hmm. So when did GLP-1s go from being just another diabetes medication to something that's useful for weight loss?
So this class of drug is not new, have been on the market for some 20 years. As you have stated, it was first developed as a type 2 diabetes treatment drug. At that time, we start to observe patients on this class of a drug not only have lowered glycemic response, but that also come along with associated weight loss. And then the industry and the started to have clinical trials have weight loss as the primary outcome, and turned out to be that it is true, and therefore they got FDA approval to have weight management or weight loss as their primary indication of this class of a drug. Now we're looking at the second generation, and semaglutide is the first one, and that brand name is Wegovy. So that is probably, we get started with this new era of GLP-1s for weight management.
And when we think about older adults, my understanding is that many of the landmark trials for these drugs included older adults in the studies, but not necessarily frail older adults. And I'm wondering how you sort of view the data we have.
Okay, you are absolutely right. And those studies are done mostly with a population middle age. And some of them are women dominant. There are senior citizens included. That is one thing we need to pay attention. The second, it is related to one of the concerning side effects that come along with weight loss produced by this class of drug, that is muscle loss. When we talking about weight management, we kind of automatically, or most of the time, we'll think, okay, standing on a scale to look at how much do you weigh. If scientifically looking at this, and then we really wanted it is for people to losing fat, and particularly the fat in the upper body, the truncal fat, because that is associated with negative health outcome and increase your risk for metabolic diseases. Typically, particularly in non-elderly population, weight is a very good surrogate marker for fat loss. But with this class of a drug in particular, there seems like more lean body mass, including muscle loss. That is of particular concern because when we're getting older, when you limiting your, let's say, dietary intake to lose weight, you start to see more of muscle loss together with fat loss. That is just come along with aging. There have been studies showing if you're older than 50, let's leave the definition of geriatric for a second, you start to losing weight in a range of 30 to 50% of weight loss is muscle.
Wow.
All right. That is not all the bad news. If you gain weight afterwards, you cannot maintain, and you are older than 50, and the weight gain is almost 100% fat. So you can see if you go through one round of this weight loss, you end up in a not so healthy state, and particularly for health concern. That is another point I really want to bring up. We talking about weight management, weight loss, and we have to also realize it doesn't matter how much weight we're looking at to lose. The ultimate goal is for better health. And that is particularly important for our elderly population. They may not need to lose so much weight, get to the point, high school weight, or at the time they get married. But that does not necessarily mean they're not able to achieve a better health state. And then people often say, hey, how do you know they have lost muscle or they have lost fat? And clinically, we don't have really effective tools conventionally to judge that. And we often say, okay, if it's something we cannot do, what are you talking about? There are actually very important clinical tools to assess overall patient condition, particularly with the elderly. That is functional status. And you can ask a patient, together with the weight loss, are you able to do more physically? Are you able to walk more, walk faster? When you do, a strength test, even hand grading, are you able to have more strength? I think that it is more important than their body weight to gauge the patient's overall health status. It is the most reliable way to judge and the success of a weight management with this class of drug or with other modalities, to help them managing their weight.
And Dr. Li, when you're starting these treatments, what endpoints do you use to decide when a patient's achieved their goal, and we can maybe dial back the therapy?
Okay, and I'll address the first one is how do you gauge. Second one is a separate issue, that is how you dial back. All right, so I would say weight management ultimate goal is for better health. I would work with each individual patient to really get to the point. You have lost enough weight, but not, in any way for you to be in a less functional state. That is very, very important. As we know, body weight, the BMI, it is a J curve, meaning, when you're gaining weight, you increase mortality. But when your weight is too low, you increase mortality as well. So from weight, there is a sweet window. But more importantly, to look at their body function. If they have lost, 10 pounds, they can walk better, and they're happy with it, there's really no reason for them to lose 20. If their individual, lost 10 pounds, but, I still have trouble getting around, or my blood pressure is still high, or my glucose still high, increase the dose. And I would say, though, take your time. For elderly, it is important not to have crashing weight loss. The reason is the faster you lose weight, particularly you don't have really diligent consultation or monitoring on nutrition status, nutrition intake, you're losing too much muscle. And realize the muscle is not just your legs and arms. Your heart is a piece of muscle. Your diaphragm and for breathing is also a piece of muscle. It is really impact on your entire body function. We typically, for elderly, would be happy with a weight loss rate about half pound a week, no more than a pound a week. And that way, you can losing weight steadily, but you have time to work with your patient to make sure they are not just cutting calories to the point they hardly eat anything. They get enough their protein, they get enough vegetables and fruit, and they get whole grains, and so they get the macronutrient, micronutrients, and not to run into deficiency. That is, we at UCLA, we have a group really working with our patient step by step to achieve better health. I think that you and I both should be proud of UCLA Health, and we're not only just prescribe the drug, okay, and wish you the best. We actually have specialists like you take care of the elderly, and there are folks like me also come in, partner with you, not only, for them to lose weight, but, more importantly, mind their overall nutrition status. Hopefully, during this weight management process, they will have better lifestyle. So your second question is, when do I dial back? That actually is a tough question. And as I have stated earlier, particularly for elderly, gaining weight or weight recycle, it is more negative than, you were heavy or overweight to begin with. That really has to be individualized. Do you keep them at the same dose so they can maintain weight, or you start to extend your time intervals between the between doses, or you lower the dose, or you're going to add another drug to it, or the patient during this process, you have done such a beautiful job. They really have changed lifestyle, make you feel okay. They can just continue what they have learned, and then you'll be able to maintain weight, maintain your function. That will be ultimate the best. At UCLA, we do research, also trying in clinical practice, and to adding medications such as metformin. And that really help the patient able to maintain the weight and increase your possibility to decrease the dose of GLP-1 or weaning them off GLP-1.
And I'd like to ask you about patient selection. I think this is one of the hardest questions, especially in geriatrics, as we try to balance between metabolic goals and also with sarcopenia. Would it be okay if we run through a case?
Of course.
Okay. So I actually saw this patient fairly recently. He's 85, he has type 2 diabetes, managed very well on orals. His BMI is 35, and his goal is to lose weight. He lives by himself, and he's starting to have trouble with mobility.
How much does he weigh?
Yeah. He was around 300, 350 pounds. And, I noticed in clinic he's having trouble just transferring out of the chair. His thighs are pretty weak. He's not yet at the point where he's needing assistance with the transfers, but I'm worried that in the coming years he'll start to have more issues with mobility. So we're wondering, would starting a GLP-1, could that help restore his mobility in the long run by taking some weight off, or would it maybe worsen his mobility through sarcopenia?
And first of all, he has diabetes. That have him in a very different category, particularly if his glucose is not well controlled. GLP-1 definitely need to be added to his regimen, for sure. As to weight management, and I would, really get him started. He's a man. He has a lot of weight. That means he actually have probably more muscles than someone who only weigh 180 pounds, because you carry the weight around. Even he has problem to, transfer himself. He does have a muscle reserve to start with. However, with his age, there's also a concern. He already experienced we called anabolic resistance. That is, his organs are less effective to use the nutrients coming from food than a younger person. And particularly protein intake. You and I take 20-gram protein, we can use it efficiently to support the skeletal muscle or the heart. But for him, he may only able to use 15 or even less because it's the anabolic resistance. So for him, along with the weight loss, I would love to have him work with us. We are a multidisciplinary team. They're physician like me, specialize in nutrition, dietitian, and physical therapist, and also behavior therapist to really work with him to see what is the best for him. You told me he lives alone. I mean, he hardly ever cook probably at that age. What is the prescription for his, nutrition need, and what is the plan to carry out that? And also be mindful his financial capabilities. And he's not going to be able to hire a chef, for example. I mean, we have been doing very successfully to work with him. What does he like? And what is his cultural like of food? If he's going to say, I'm a meat potato person, okay. So we may have to start with there. If he have to have his red meat, but we will limiting or work with him limiting the carbs. You can have your steak with roasted broccoli or cauliflower to go along, but not have the potatoes. Or he say, I must have potatoes this meal. Okay, the potatoes are already the carbs. You cannot have more carbs on it. Probably potatoes should go along with some protein, chicken breast, piece of fish. And depends on his like and his financial status. The vegetables does not have to be fresh. Does not have to come from, farmer's market. I mean, they're frozen vegetables. We can teach him how to use a slow cooker or cook it very efficiently and very financially manageable. And there's also, all kind of meal supply companies if he financially could afford it. Lastly, is not a whole food, but there are all those protein drinks, right? Take example of like a many, well, let's not mention brand names. Typically, one carton, it is 25 to 30 grams of protein, and it costs you about $2 if you have that with an apple. I mean, that would be a good nutrition-wise meal to meet his body need, nutrition, macronutrient, and micronutrient as well. I think that is something we take pride and to work with you as his primary physician to not only just judge the success by the weight per se, but at the same time ensure we're not really produce or induce any harm. And hopefully together we'll get him to a better health condition, better glycemic control, and lose some weight. He can be more mobile. When he's more mobile, you have more drive for your body to be more efficiently to anabolically use the nutrients. So it's a good catch-22. And when you managing an individual for weight, you manage an entire life. As you know, there's so many factors play into it. It's not as we used to think a calorie balance issue, right? You just gotta eat less and walk more. No, not at all. And we learned through, the first dietary guideline to the new ones. We definitely learning from our lessons.
Yeah. Thank you for sharing. So, it sounds like for this patient, we would be thinking about a GLP-1 based therapy, but as part of a holistic, multidisciplinary approach to achieving his weight loss and metabolic goals. So let's say we were thinking about prescribing a GLP-1. We have multiple options now for weight loss. How do you go about choosing a specific agent? Are there pros and cons we should be aware of for each option?
So first of all, the effectiveness of all those drugs varies widely from one person to another. So with that have said, it's not true, a dipeptide or tripeptide would work better than, semaglutide alone, or liraglutide, the first class. That is something we need to understand. Now, come to which one you're going to use first. It also has a lot to do with insurance coverage. If it's insurance covered, and that for many of our patients, if not all, would be the first reason to pick up particularly one. Now there are a lot of self-pay options as well if the insurance is not covering, and that play into decision making as well. This is the first go around. For your patient, 350 pounds, there is, as a man, there's a very high likelihood he would have obstructive sleep apnea. If a study confirms that, that actually will give you a much higher chance to get insurance coverage. I bet at that age, he's having Medicare for SET bond because he has a specific indication for OSA, and that probably would be my first choice if he does have OSA. I would not at that age to add significant financial burdens from a medication. And particularly we have to, walk him up in the dose and take a time to get to where he needs to be. So that would be the first go around. After you start the medication, and if the patient has side effect, and then that's the time, depends on what is the side effect, you can adjust to other medications. And particularly if they are not losing weight or have particularly severe GI side effect they can't tolerate, and you can try a different one.
What about the oral agents? We're hearing more about GLP-1s, but now they're pills.
Right. Generally speaking, this is for clinical trials. The orals has not been as efficacious as injectables. It has a lot to do probably with the compliance. Pills you have to take every day. An injectable is one injection for a week. So that is what we know from the clinical trials. But the pill, it is obviously a choice, and also have other benefit, particularly for folks who travel. And the injectables, you have to keep it refrigerated. Pills, you can just take anywhere. So does give you that kind of benefit as well. From our experience, since we see many of those patients now, it depends. But still, we see a little bit better weight loss with injectables than the orals. There are also the difference, the injectables, you have a wider dose range to pick and choose. The orals are much more limited as well. Yep.
So let's say we're starting this patient on a therapy. We've selected an agent. Mm-hmm. Now, you would mention things like protein intake and physical activity. Do we have evidence that shows that interventions like that can reduce the amount of lean muscle loss while patients are on these therapies?
Okay, number one, there are active clinical trials looking at that, but at least we do not want patients, particularly at geriatric age, to reduce their overall intake by cutting out everything. Definitely do not want them to cut out proteins for sure. And overall suppression of the appetite, it is good, but ideally for health purpose, you want to cut out the refined carbs. You want to cut out the fat, but you don't necessarily want to cut the protein intake. Particularly, they are less efficient to use the proteins along with the aging. So that is the first thing we need to let the patient know. Yes, when you have less appetite, eat your protein first. followed with your vegetables. And if you have no more appetite, you don't have to have your carbs, but you cannot do the other way around. And, often, and, the margin between, protein deficiency or not is, small with geriatric patient. So that is the first thing we would do with a patient before we think about are they able to, preserve more lean body mass. The first thing, let's not get them to protein deficiency, because then you worry about their immune condition and overall body function as well. So that's important. The second is vitamins, and that ideally come from fruit and vegetables. If not, then they should take a supplement. Multivitamins widely available. You do not want to deal with deficiency either. We actually have observed clinically folks on the edge of thiamine deficiency. Now on GLP-1s, they start to showing symptom of a thiamine deficiency. We even now have cases reported. People develop Wernicke-Korsakoff, for example, and that would be not something we want to have.
Especially when it's so easily preventable.
Right. So that's back to what I said. We want to use those tools to have our patient eat better, more active, to have a healthy lifestyle. It's not easy, particularly there is there's a tendency on the drug for you to more want carbs. And the reason being, naturally, we do secrete those peptides ourselves. You secrete the most with the high protein meals. So now the brain think, since you get an injectable, we have enough of that. We could have others, the dessert. So that is kind of put us in a more challenging situation. Patient education can help to really counter that part of it. So that's what we need to do.
What other advice do you give to patients who are prescribed GLP-1s?
So number one, we start to manage the expectations, and we will start to talk about the goal. Why do you want to lose weight? And it's very important, particularly as a physician, to focus on better health. We usually identify one specific goal for your patient. For example, we want you to be able to move around better. You can actually clean yourself, even go to the bathroom, you can wipe yourself, you can do all those very personal things yourself. And then we set that first. We'll follow up every visit for the patient to feel and to know their progress. I think that is the most important thing to start with. Secondary, we would really wanted to looking at how overall they feel. And there is another side effect come along with this class of drug, this actual mood change, depression, when you suppress the appetite too much. So we would manage that as well. And then you're looking at, how much weight you actually lose.
How would you manage these mood changes? Can you reduce the dose? Is there anything else you can do?
We can reduce the dose and also looking at the nutrition intake. For example, you need the tryptophans and you need an adequate protein intake, or you can have patient take more nuts, like tree nuts. One of our earliest studies of our own has demonstrated 90% of serotonin is made in the gut. It's not in the central nervous system. And it is a result of the food we eat, the gut microbiome, and our neuroendocrine cells. Those work together and to really control our mood. Butterfly feelings or gut feelings actually really have scientific evidence there. So to answer your question, lower dose is one thing because depression is such a significant side effect. But we would look at the diet and food and outdoor physical activities and social companions and all of that would play a role. Yeah.
And we're starting to see more patients who have been on these therapies for years and years doing well, and now they're, reaching kind of the end stages of, their other organs and kind of nearing the end of their life. And I'm wondering how you approach adjusting or using GLP-1s for patients who are kind of at that stage in their life.
Okay. First thing, positively, GLP-1 through the weight management and also directly has been having benefit on, cardiovascular disease. Now there's some evidence may be beneficial for CKD as well. Hopefully that would be positive. If it's more advanced towards more end of life, I think it's a discussion with the patient. Particularly to address their goal, what does matter most to them? If they wanted to really, I want to be on it and I want to be, not gaining weight, and even at that stage is the one thing. If they say now quality of life matters, and particularly you see they lost muscle mass or had impact on their mood, I would aggressively, wean the patient off those kind of class of drug. Even they have diabetes, I would use other glycemic control modalities. Yep.
Thank you. I think this information will be very useful to me and to our audience. Okay. I'm wondering, is there anything else you'd like to plug or share with our viewers?
I think I just want to reiterate, weight management is truly for better health. And I say this because we also see in non-geriatric patient population, along with this class of drug use, come along with eating disorders. That would be not the purpose for us to use this class of drug in spite of a successful weight loss. And we as physicians, and our overall goal is to help everyone live better, live longer, and not anything but that. The second thing I want to say is this is only one tool added to our toolbox, and this is definitely not the cure for obesity. We need to use those tools wisely. And remember, we are still the one, drive the whole healthcare. We need to practice medicine, individualize our approach with everyone. And not everyone's a good candidate for GLP-1. Not everyone needed to be on semaglutide. Sometimes liraglutide will work. And there are times, and they would benefit actually from other options for weight management. And particularly if we think about weight is a kind of overall reflection of many different things impact their life, not just energy intake or activity. There could be sleep, there could be psychosocial, where do they live, air quality, air conditioning use. There's so many confounding factors. And we needed to practice individualized medicine and hopefully one day precision medicine.
Absolutely. That's a very important reminder to us all.
Yes.
Dr. Li, thank you so much for joining us today.
All right, my pleasure.
If you're interested in hearing more about this topic, please join us for the UCLA intensive course in September.